Hi, everyone. This is Polly Kurtz. Welcome to the PCBH SIG monthly meeting. You should be seeing the agenda on the board. As usual, I'm going to go through the process of unmuting everyone. And if you will take a moment and mute yourselves, there's the little green microphone button in the right-hand side of, it's actually the left-hand side on the right hand on your control bar. So if you'll mute yourselves. One thing that I have learned is once I unmute you, if for some reason somebody's unmuted and I'm forced to administratively mute them because there's background noise, I can't unmute that person again. So it does create some chaos and folks having to log back in and stuff. So if you can just make sure you're muted unless you're talking or need to talk, I think that would work great. And also I'll be monitoring if somebody has a question and wants to type it in. There's the little question bar at the bottom of the control panel, and I'll be monitoring those. Okay, thanks everyone. I'm going to turn it over to the co-chairs, Jeff and Chris.
Jeff, are you there?
I'm here. Okay, I was
right.
muted, but yeah. So hopefully everybody can hear us now. We're getting a lot of background noise from somebody. Okay. So, Chris, can you hear me okay?
Yeah, I can hear you just fine. Why don't you go ahead and start off, and we'll just trade off back and forth, okay?
Sounds good. Okay. All right. Well, welcome, everyone. We will just run through the agenda here. Mostly what we're going to be doing is getting updates from the different work group chairs. And there's been a lot going on, a lot to update. First, a reminder, I'm looking at item number 2 here, just a reminder that we do have a listserv. You can see the address right there, pcbh-sig@maillist.com. If you have anything that you want to post, any kind of announcement or anything, feel free to use the listserv. It's starting to get a little more action lately, which is great. And going then into ongoing business, Chris, you want to start with the research?
Yeah, sure. We're going to flip the order up here a little bit since Jennifer Funderburg has to leave early. So, Jennifer, if you could go ahead and give an update on the research committee. Was there? Did she leave us?
It looks like she may have had to leave the call.
Yeah, I don't see her there anymore. She was there at the very beginning. Well, okay, we'll see if she logs back in later. But I know that she had said initially that she had to leave pretty early on in the meeting. So she might have had to take off. All right, well, let's just continue on with the webinar workgroup update. So I believe I see Randy's name here, which is great. So Randy, do you have an update on what's going on with the webinar workgroup?
Yep, sure thing. So really we're just plugging along. We're really excited that the first webinar that we are launching will be on October 8th at 12 p.m. Eastern Standard Time. And Travis Kops will be presenting an overview of the PCBH model. So we're gearing up for that first webinar, and we'll have more information as we get closer. And then the other 2 upcoming webinars that we have are November 12th at 12 p.m. Eastern Standard Time and that will be Jeff. You will be doing the PCBH program, if I wrote that correctly.
Okay, good to know.
And December 10th at 12 p.m. EST will be Patty Robinson, Interventions in PCBH. So we're excited about that, and we will have more updates as we get closer. We're also looking into next year, booking some interested webinar presenters. So if you are interested, please feel free to, first of all, if you're interested in joining our group, you can email Robin. The email address is there. And if you're interested in presenting a webinar, I guess you could send it to my email, which is under 3B, and I will circulate it to our group. So that's pretty much our update.
Great. And members are going to be able to get continuing education credit for this too, right? I don't.
Yes, that's what we're working towards. Yeah.
Mm-hmm.
So
Great.
we meet as a group again next week, and there will be continuing work on the CE piece of this. Yeah.
Outstanding. Sounds good. And we looked at the content that Travis intends to present on it in his presentation, and it looks really, really great. So encourage anybody who's interested to check that out.
So tell us about the social outing. Where are we at with that now?
So the social outing, thank you to everyone who RSVP'd. Right now I'm in communication with a staff member at the hotel. I'm trying to see if there's a section of the hotel bar that is in the kind of lobby-ish area, and I'm working to see if that would be a good space for us. I've had about 30 people say that they're interested in joining, and that was just from the listserv. So I'm expecting a nice group of people and trying to make it so that it's somewhat private and also that we're able to mingle with each other.
Mm-hmm.
Yeah, that sounds great, and it sounds like as you're able to finalize things, if we could maybe get a final email push out to our listserv maybe a week or two before the conference, that would be great.
And somebody has some interesting background noise going on here. If you take a note there, if you're not muted. Not sure what's going on. Okay, it sounds a little bit better now. But sorry, what was your wrap up on that, Randy?
Oh, I think Chris said something.
Are you saying it sound like Randy, Jeff? I think.
Okay, or Chris, whoever.
I thought like this, Jeff. Is that better?
Okay, that's more distinctive. Yeah, very good.
I think we were saying
Chris.
If Randy could put out an email to the PCBH listserv maybe at least a week before the conference with all the final information, you know, where it's going to be, what time, what area. That way, I think we'll capture as many people as we can. So it sounds like it'll be fun. It'll be nice to meet folks. I mean, I see all these names and I hear voices, but a lot of you I've never met before, so it'd be nice.
And it will be held ideally 6:15 to 7:30 to accommodate as many people as possible.
Great.
Yeah, great. And we know that there's there's the Moonlight trolley tour. I know some people are interested in taking, and I think, you know, some people are going to probably just come to the beginning of the social outing, and then if they need to take off for that, I think that leaves around 7. You know, people could at least come in for part of the social outing and, you know, meet some other folks and then take off a little early if you need to. But yeah, sounds like it'll be fun.
And
so thank you.
And Randy, this is Polly, if you want to shoot me the details as you kind of have those firmed up, we're going to do conference email blast announcements each day to conference attendees, letting them know what's going on so we can include that in there as well.
Okay, great. I will do that.
Very good. So, all right. Is anyone on the call to talk about item C there, 3C, the from the toolkit committee? I don't know. I don't see David's name signed in here. If you're from the toolkit committee, if you're on there, you know what's going on, feel free to chime in. I know that they've been, or is Suzanne on here? Let's see. I know that they've been working pretty closely with the FAQ work group and Suzanne and are getting ready to launch a number of things. But anybody else have any more specifics on those? Either C or D?
Looked like, I think in the last email I saw from David that they were hoping to have some materials on the website by the time the conference rolls around. So I guess more to come on that in the next month or so.
Okay, yeah. And I think the same is true of Suzanne, actually, with the FAQ section, FAQ work group.
Yeah, so literally within the next 6 to 8 weeks, we're going to start to see products that are available for our members to take advantage of, and I think that's to all the hard work that the different committees are doing. It's without what you guys, what you men and women are doing, we would not have this stuff, and it's been nice to see the progression of what you're able to do, and the draft products we've seen so far are looking really, really nice.
This is Stacy Gideon. I think I saw that Suzanne was going to try to call in.
Really? Okay.
I think she was trying to.
Oh, you know what? I actually got it. I'm checking my email here. I have an email from her. It says, "Do you have the call-in number for the SIG meeting?" Okay. So, all right. Maybe, Chris, if you want to take the helm here, I will forward her the login information.
Sure.
Okay.
So why don't we switch to the outreach and branding? I think I saw Robin on here earlier. Robin, are you on?
Hi, I'm here. Yes, sir. I'm here. Can you hear me?
What? I can hear you.
Okay. So for the outreach branding, we have an update regarding a flyer that we'll be passing around at the CFHA conference specific to our SIG group. So it's just a flyer, a one-page flyer about the PCBH SIG, sort of what we do and who we are, how to join us if people are interested, or where to get more information. So I think our plan is to pass that out alongside the conference booklets. Is that correct? Or we have the flyer made. I guess I'm not sure exactly how we're disseminating it yet.
Sure, Robin. This is Polly. I think our plan is to put a flyer in every conference packet of information for all of the attendees, and then we're going to make some extras and keep those at the CFHA membership desk, so when people are inquiring about membership, they can get more information about the PCBH SIG then too.
Right. And let's see. So we also have, should I mention the ribbons real quickly that we're going to be wearing? I think we decided on navy blue. Our name tags will have little navy blue ribbons with gold lettering that say the PCBH SIG, or maybe just PCBH. That will also identify us on our name tags. as people to talk about for kind of spreading the news. So we're moving along.
Polly, updates on the ribbons?
So they haven't been ordered yet. We ordered the whole thing in bulk for all of the different ribbons, and we usually try to wait until we have a pretty good count for the conference totally. So I would bet we'll probably order them by about the 15th of the month,
Okay.
which will give us plenty of time.
Sure.
Cool. Okay. Thank you.
And then so anybody who's a PCBH SIG member, that would be a ribbon that they would be able to put on their name tag if they wanted to do so. Is that correct?
Correct. And I guess what we'll do, guys, because since we didn't have this idea necessarily when we started the conference registration, so we don't have people like check a box to say that they're in PCBH SIG, we'll just make them available for people who want to add those to their ribbons. You know, some of the ribbons we hand out, but in this case, we'll just make them optional. Are you guys okay with that?
Mm-hmm.
Yeah, and I think what we can also do is a week before the conference, go ahead and send out a reminder email to the listserv letting folks know that that ribbon is going to be available for them to pick up and put on their name tag if that's something they'd like to do.
Perfect.
I can certainly do that or check in with you, Polly, about that when we get close.
Yeah, that sounds great. That sounds great.
Great. Yeah, hopefully it'll be something that helps to just stimulate discussion too amongst other CFHA members who might not be in the SIG. So, as well as helping to identify, you know, put some faces to names as you go around at the conference meeting people. So, okay, fantastic. That takes us back to research, and it looks like Jennifer was never able to rejoin us here. But we do have Chris on the agenda. Do you want to go through, tell us about what you all have been doing at the DoD as far as program evaluation?
Yeah, I'd be happy to do that, but I'm wondering, you know, before I launch into my stuff, I'm wondering if there's anybody who's called in today that maybe has some research agendas or projects that they might be interested in discussing or getting input from other members. We didn't receive any emails ahead of time, but I thought I'd just go ahead and ask, or any kind of program evaluation questions folks might have. So you have to unmute yourself.
So any projects they might be considering that they kind of just want to discuss, or even if they don't, not looking for input on it, just to give an announcement about it, that sort of thing.
Sure, we've had plenty of time today.
Mm-hmm. And this is something that we're going to have, remember, you know, as a standing item too. So, you know, there's be plenty of opportunities in the future too. If you got some project you've been considering, you want to talk about it with the group.
This is Mark Vogel. Can you hear me?
Yeah. Hi, Mark.
Hi. So one of the questions we are struggling with, or not struggling, but looking at as we evaluate change is some of the metrics of reliable change within IPC, and using some formulas that have been published in the literature about reliable change, and trying to apply that to also some of the other measures. The GAD-7 PHQ-9 is nice because you can find some of the published norms on it. So looking at what constitutes moving someone from moderate or severe depression to a reliably different category, and just wondering what other researchers are doing when they're kind of helping to document this in their studies.
So are you asking what tools people are using for documenting clinical change, clinical outcomes?
Yeah, really looking at statistically how you're documenting that improvement. Again, the measures we've been looking at are some, I'm trying to find my article right now, but it's basically using the norms of the measure itself to then look at what is statistically a significant change of someone from one category to another. So looking at pre-post measures and using the mean of a normal population and your pre-treatment population mean, and using the standard deviation of a normal population and the standard deviation of your pre-treatment group to come up with what is a reliably different value. And so again, didn't know how other people are approaching that methodologically.
Is that something that you've brought up to the research committee?
Not, sorry, my phone's ringing, I can't answer. No, I have not. So I just bring it up here. Is that a better way to approach it?
Yeah, I think the question you're asking, as I'm understanding it, I think is a pretty complex question that I think depends on a variety of things, like the age, socioeconomic status, healthcare status of the people that you're seeing. And I think that you're probably approaching it very much like a research scientist as opposed to somebody who's looking at more kind of general programmatic clinical change, and I appreciate that approach that you're taking, and I think it's complex. And I think another piece of the complexity that goes with that is that if you're looking at, like the PHQ-9, if you're looking at score changes on a PHQ-9, depending on what level they started at, that score change could be statistically significant, but if you have another measure of clinical functioning change, you might find that how they function really hasn't changed that much. Have it the same way. You could have somebody who maybe doesn't have a statistical change that's significant on a PHQ-9, but if you look at another measure in terms of how they're functioning, they may be functioning drastically. So I think it can be really complex. And I think that would be, I mean, I don't have the answer to that, but what I'd love to have happen is for you to bring that to the next research committee meeting, which I believe is tomorrow at 1, I think. And if you're not there, I think I'm going to be able to, and I can bring it up. And see if the research committee would maybe put together a subgroup to maybe look at that more specifically, and then can bring it back and give a talk to our SIG, or maybe have that as a webinar topic that is both can be clinically meaningful as well as be meaningful when folks are wanting to report and republish their research program evaluation findings in peer-reviewed journals.
Chris, great suggestion. I will take you up on that, and I appreciate your thoughts.
Any other thoughts? I mean, I mean, we've got good expertise on the line. Anybody else have any thoughts or comments on what Mark's talking about?
Hey, Chris, this is Polly and Mark. We are in the SHAPE project that CFHA is a co-partner with Rocky Mountain Health Plans and the Department of Family Medicine at CU Denver. They are also trying to do some longitudinal tracking in our patient populations of the PHQ scores. And Mark, I will via email offline connect you with the quantitative research staff at DFM who are working on that project, and they may have some ideas about that too, and I'll frame it up for them, at least to my limited understanding, not being a researcher, but just being kind of connected to that project, and they may also have some ideas about that.
Again, thank you very much.
Any other thoughts or comments? All right. So I'm going to go ahead and just give a brief overview of some of what we're tackling in the Department of Defense. So for background information, the Department of Defense has mandated in the military health system, which has over 3 million individuals enrolled by name, 3 million adults enrolled by name to primary care providers. It's mandated that for every clinic that has at least 3,000 enrollees, they have to have one full-time behavioral health consultant working in a primary care behavioral health model of service delivery in that clinic. And as you can imagine, people that pay for these providers and people that have said this is a, we think we're buying your argument about why we should integrate these folks into our patient-centered medical home primary care teams. You can imagine that over time, when you have over 300 full-time behavioral health consultants working in these patient-centered medical home primary care clinics, that they're going to start to ask some questions about, well, how do we know that what you're doing is making any difference? So we made the argument ahead of time about here's what the research says, here's what our experience in the Army, Navy, and Air Force suggests, because we had been doing this sort of in our own little towers of excellence at different clinics across Army, Navy, and Air Force. And so we were funded with this, and we have policy that mandates that it has to happen. We have standards for training. So part of what we're doing right now is we're launching a very large program evaluation. We have structured our electronic medical record so that all of our behavioral health consultants have a module in our electronic medical record that they are mandated to use for every patient, every appointment. Within that electronic medical record, there are different tabs for different problem presentations where they can go and click on boxes, enter scores for measures that they may be giving individuals. It's supported with point of service, evidence-informed and evidence-based recommendations for assessment and intervention for the folks they might be seeing. And what we're doing is we're now launching, actually is launching right now, we're writing the code to pull data on all of our behavioral health consultants. We have about 240 actually in clinic right now. We'll be about 311 when we're fully staffed. But the idea is we're going to pull data on all of these behavioral health consultants, every clinic, on every patient, on every appointment that they see. We're going to be looking at process and outcome metrics. When I say process metrics, part of what we need to know is, of a population, what percentage of that population are our behavioral health consultants seeing. So part of the data we'll be pulling would be in a given primary care clinic in a given month, how many people came to see their primary care provider, and what were their unique demographics, what were the unique mental health or other health diagnoses that they were given, and then of those individuals, how many of them were referred to see a behavioral health consultant. So it gives us the denominator of the people that could possibly receive a behavioral health consultant appointment within a given month to the number that actually see the behavioral health consultant. And then of those that actually see the behavioral health consultant, how many appointments did they have, what were the unique demographics, and that we've mandated that for every appointment. Currently, what they're getting is the Duke Health Profile, and we are transitioning this month to the Behavioral Health Measure 20. And we are able to put both the total and subscale scores in our electronic medical record, which we can pull out electronically and pair up with a whole host of other demographics and healthcare information that we can pull out of our electronic medical records. And we're going to be looking at those process and outcome metrics for those patients every quarter, as well as any other measures our IBH, our behavioral health consultants might be given. So they may decide, in addition to these more global measures, that if they're seeing somebody for depression, they may want to give them a PHQ-9 or a GAD-7 or a PCL or an audit or one of the pain measures that we're using. So that's sort of it in a nutshell. We've got a lot of data that we're pulling on all kinds of providers, and it really allows us to look at a given provider in a clinic. If a clinic happens to have more than one provider, clinics within region, clinics within the Navy, the Army, the Air Force, we can compare clinics. And so it gives us a chance to look at, one, are you doing the things that you're supposed to be doing? Are you checking all the boxes? So if every patient on every appointment is supposed to get a BHM-20, and we pull all the data, and only 50% of those patients had BHM-20s, well, we have a problem. And so it allows our service-level program managers to go to the clinics where this isn't showing up and figure out what's going on, because it's not an option not to give these patients this measure. Now, it may be the patient refuses to take the measure, and so they can do a little bit more detailed look there. It also allows us that as we're implementing different clinical pathways, it allows us to look at kind of how the consultations shift. We have our Navy within the next month is about to roll out an obesity clinical pathway, so that when a patient sees a primary care provider, if they have a BMI of 30 or greater, as well as a variety of other ways to look at folks that might benefit from a behavioral weight loss intervention, as part of standard care. If somebody comes in, they have a BMI that's 30 or greater, the primary care provider says, hey, are you interested in maybe losing some weight in the next month? And if they say yes, then part of standard care is they have an automatic appointment with the behavioral health consultant as part of a team approach to helping that person develop and maintain a weight loss plan. So we can sort of look at, over time, when the Navy's pushing theirs out, how many more people are behavioral health consultants seeing for obesity assessment and intervention in comparison to a like group of individuals in the Army or Air Force that are not pushing out a clinical obesity pathway. And we can see, is this pathway, is it getting more folks that could benefit from a behavioral health consultant service? Are they getting there? And of those folks, is their weight dropping over time? Is their body mass index dropping over time? If we look at other health measures, if they happen to have high blood pressure or high cholesterol, is that changing over time? Because we might change their body mass index, but other health indicators may or may not change. So it allows us to sort of go in and look at, well, okay, what kind of additional impacts are we having on these individuals' health over time? So it's a pretty heavy lift, and it's taken us a long time to get here. We designed our electronic medical record. It's called a tri-service workflow form. We had all the primary care subject matter experts, as well as the behavioral health subject matter experts, design this for our behavioral health consultants, and we've tweaked it over time, and we designed it in a way that allows us to pull hard data and run data analysis on it, instead of pulling data that's out of a text field and having to have someone scan through the text field to pull out the relevant data to analyze. So you can imagine all the data points. If we're doing quarterly data pulls on roughly 300 providers on all patients, all appointments. So it's getting worked on right now, and I hope to be able to, within the next year or so, report on some of what we're seeing in general to this SIG, and we're certainly going to report it to our stakeholders and our funders and our leaders, and we hope to publish our program evaluations in peer-reviewed journals as well. So that's kind of it in a nutshell, and I'm happy to take other questions if you want to know some specifics about anything I didn't cover.
I'll just say it sounds great, Chris, and very excited to see, what the numbers show.
I am too. I mean, because part of this is, we need to be able to show is the impact we think we're going to have, are we actually having that? And so at the very least, I want to be able to look at and say, you know what, when somebody sees a behavioral health consultant, on average, from appointment 1 to appointment 2, and our mode number of appointments that our patients are seeing a behavioral health consultant is about, I think it's 2.1, I forget.
Mm-hmm.
I mean, it's not.
That's about what ours is. Ours is about 2.2. Mm-hmm.
Right. So we have to see, they have to have at least 2 appointments for us to see a change. But we've done a proof of concept data poll on this, and when we looked at the Duke Health Profile for it was 13 different clinics with 20, I forget the exact number, like I think 23 providers. We could say that of the patients that saw a behavioral health consultant that had at least 2 appointments, that they had a statistically significant change in their scores on the global health measure of the Duke Health Profile, and that we also had statistical changes on the subscales. We've got permission to use the behavioral health measure 20. We're actually have paid for that. We're going to be able to, we've got a scoring program where we're going to be able to score that up. We're going to have kiosks in the future where the patient checks in and is able to, not only on our behavioral health measure 20, but on other measures if we want them, to use a kiosk or a tablet and fill that out electronically. It's scored up automatically and can be imported into our EMR. So there's a lot of exciting things that we've been able to do in about the last year and a half that really weren't possible like 3 or 4 years ago in our system. A lot has changed, and part of that change is policy. And I'll foot stomp this. I think if you're looking to do something within your individual clinic or a system, it's really important that you have very specific policy about what kind of model of service delivery do you want to do. How are you going to train those people? How are you going to monitor those folks? How are you going to pull data from them? What are your targets? What are you looking to have happen? Because if you don't, people just tend to go out and do what they're going to do, which is what happened in the Army, Navy, and Air Force in the past. But now we have a Department of Defense policy that says, yeah, no kidding. Really, you have to have one full-time person in that clinic working in primary care, nowhere else. Oh, and by the way, they have to have been trained by an expert trainer before they can go in primary care. It really allows you to have, I think, a lot more fidelity to what you're doing. And if you don't have fidelity to delivering a service model, if you're assessing something that doesn't have fidelity, I don't know that assessment I don't know that it really means much,
Mm-hmm. Mm-hmm.
A lot of silence out there. No questions, no concerns. How do I do that in my clinic? Crickets. Nothing but crickets.
Well, I think, I would say.
All right, so I'll
go ahead.
This is Mark. I'll jump in one more time. So Chris, interested in how you chose behavioral health measure 20 over their 10 version, and why over Duke?
So we've used the BHM 20 in the past in our primary care clinics and have been able to do them quickly. And we chose it over the Duke because we thought it we thought it more generally helped us to look at a bulk of the problems that were going to come in, as opposed to the Duke, which might ask some questions that might not apply to some folks. Now, you could make the argument either way. I think another thing that was a selling point for us for the BHM20 is that we knew that we could get access, that we could pay for the access to all the scoring algorithms, and that we could own that on our own server and have our own data and have that incorporated into what we did on a daily basis. So part of it was we'd already had experience with it, and we knew that it was clinically useful and was helpful for program evaluation. It had a global distress measure as well as some other specific subscales that we might want to look at. It had the suicide risk questions, which allowed us to ping that up as kind of red if someone's answering positive to that. And I think the Duke has been more of a challenge for our behavioral health consultants to implement. I mean, we created an Excel scoring program for that. So there were a variety of factors that went into that. I think that's the gist of kind of what we discussed. And it took a while for us to get to the BHM20 because there was cost to it, and that's why we started off with the Duke, because it was a reasonable place to start, and it was free. We got permission for all three of our services to use that for free. Is there a particular preference that you have for the Duke or other measures over the BHM20?
No, I would agree the BHM20 is a preferred product, and I was just curious on how you ended up getting there. So thank you.
Yeah, sure. And I think you want to choose measures that work for your system. So if we hadn't had experience with the BHM20 as being a user-friendly patient tool, and this was back when they were, had hard copies and patients were filling it out by hand, that it was still user-friendly, it was clinically useful, and it allowed for, to have a measure that had, well, at least initially, its norms were on counseling, I think primarily on college counseling students, but we had started to create some of our own data pools in terms of what our people were looking like. Craig Bryan and Kent Corso have published some information, some studies using the BHM20. But the nice thing about the Duke is it is free. We're certainly, if you want to use the Duke Health Profile, we can certainly send you our Excel program that will help you score it up and give you the different scores you need, because scoring it up can be a bit complex. But you might not use, we also wanted to make sure we used a global measure, so that way we knew that we would have the same measure on all patients on all appointments, as opposed to letting our behavioral health consultants say, well, I'm going to use a PHQ-9 on this person because they're coming in for depression. And they give a PHQ-9, and then all of a sudden it's like, well, this person has post-traumatic stress disorder. Let me give them a PCL. Well, I was wrong on that. I think it's more sort of generalized anxiety with some panic disorder. Let me go to the GAD-7. I mean, if you have behavioral health consultants making unique decisions, which they could still do if they wanted to, in addition to these more global measures, I don't know that would be very good for program evaluation, because we'd have all kinds of measures that are all over the place and are basically chosen based on what the IBHC thought was most appropriate. So that was our thinking around having one global measure, every patient, every appointment. Any other questions?
I also think it'll be, this is Jeff again, I also think it'll be interesting to look at measures of model fidelity and to see how that relates to clinical outcomes, if it does at all? I mean, so when I'm talking about model fidelity, I'm talking about like the ratio of new to follow-up patients, for example. You know, you got somebody who's, you know, kind of not seeing a lot of new patients, they're just seeing a lot of follow-ups, and it's kind of it's more of a specialty model, right? Less of a primary care consultant model, or you know, if you've got somebody who's, you know, mean number of visits per patient is a lot higher than everybody else's, you know. So does that seem to have implications, you know, to other clinical outcomes? I mean, that's kind of an interesting question to look at too.
Yeah, Kent Corso, he is the program manager for the National Capital Region Medical Directorate, which is sort of in the National Capital Region, DC. They're almost considered another kind of service like Army, Navy, and Air Force, even though they're all mixed up. And so, you know, he's in charge of a much smaller number of clinics than the Army, Navy, and Air Force are. And so he's actually planning right now in looking at a fidelity to service delivery program assessment. And because he's smaller, he has the ability to move a little bit faster than, you know, Army, Navy, or Air Force that have a lot more clinics spread over, you know, all over the country. You know, we're also looking to Kent, as he can be a little bit more quick in implementing things, looking at him as almost a bit of a pilot service, that if he wants to start something new or do something and get out ahead of the other services, we can sort of look at what he's doing, and it can inform what our other clinics do. And also the same thing in other services. If somebody has a unique idea of what they want to do, somebody wants to start a sleep enhancement class, kind of looking at, you know, how did you implement that? How many people did you impact? How many people did you, in comparison to 6 months previous, didn't go for a polysomnogram because it was determined that, you know, they, through a behavioral sleep change, that they were falling asleep, staying asleep, and they were waking up feeling refreshed, you know, even though they were snoring and might have had obstructive sleep apnea. Given now that they're actually falling and staying asleep, they're feeling rested in the morning, so we don't really need to send them for a sleep study. I mean, that's money savings right there. And so being able to look at some of those things as well, I think are important. And, you know, I feel very lucky that I'm not the one that has to write the code to pull all this data, and we have a PhD psychologist who this is his area of specialty, program evaluation, and was hired to do the program evaluation for the Army's Respect Mill program, and he's going to be the person that will be running all my stats. So having somebody that can do all that and can do it on a big level like I know that he can, and collaborate with you from not just a statistician point, but from a psychologist perspective, I think is a real bonus for our system. And I think to go along with that, if some of you aren't as blessed to have those resources, I think the cool thing is you can start with this SIG to find out, hey, you know, I don't know how to do stats, or I barely know how to add 2 + 2. Who can help me with this? Who's willing to volunteer some time? Who can get me even started in the right direction of how I might collect this data as part of my normal clinical work, and then, you know, give me some mentorship on how I might, you know, analyze this data. And I think, you know, the research committee is a good place to start with that, as well as our SIG. I mean, we've got a large number of really bright, motivated people who I think are very willing to provide mentorship, help, assistance, sounding board, and I really encourage our members to reach out to our other members for that help.
And that is probably a good segue to our last item, unless anybody else has other comments or questions.
Jeff, this is Polly. I think Stacy Gideon is is going to provide an update on the FAQ section since Suzanne wasn't able to join the call, if you're okay with that.
Oh, sure. Yeah. Yeah, so we can go ahead and jump to that if Stacy's available. And I want to thank you, Chris, for that that outstanding presentation there. Really, that was great and really interesting stuff you guys are doing. So thanks for the update.
Sure. Sure.
And so yes, Stacy.
Okay, so the FAQ is moving along. We have 10 categories that we're working on finalizing peer reviews for. There was one category that Suzanne was going to send out to the listserv, having to do with practice development in commercial settings. So that's something that we're needing some help with. But again, I think she's going to be sending out that question to the listserv.
Great. And I think, and I got an email a few minutes ago from David Bauman about the just giving an update on the toolkit work group, and he was really just kind of reinforcing what Chris had said earlier. David wasn't able to be on the call today, but they're moving along, working with the FAQ work group, and going to have some content up on the website really soon. So, okay, great. Well, the last item, or getting close to that anyway, the last ongoing business item, I guess, is the opportunities for collaboration. So going back to what Chris was mentioning a few minutes ago, this is a standing item here for people just to chime in if they have projects they're working on that they want the rest of the group to know about, or if you want to solicit for help or anything like that. So does anybody have anything that they would like to discuss under the opportunities for collaboration? So this is not necessarily research, could be any sort of collaboration. If not, we can move on to new business. All right. So there are a couple of items for new business. One is that we want to remind people that the election is coming up for CFHA board positions, and it'd be great to have PCBH SIG members well represented in that, and so if that's something that you're interested in, I don't know if you want to remind people, Polly, anything about that.
Sure. Unfortunately, the deadline for this cycle was September 1st. So we have a number of folks who have submitted their material to be on the slate for our fall election. I would like to say invite all of you to be sure to review those. We'll be sending out the election ballots probably in the next couple of weeks. And your vote is important. It's really important to help guide the path of our organization in the direction we want to go. So our board member positions are very important to us. And if you didn't have a chance to submit your information or consider running this year, I'm with Jeff. I'd love to have good PCBH SIG representation on the board going forward, and please consider doing it next year. That information, we start requesting people to consider running usually in about August, the beginning of August, so be sure to be on the lookout for that.
Okay, so scratch what I said about running this year, but do vote.
Sorry, Jeff.
Do vote and run next year. Okay, guess we missed that one on the agenda there. All right. Okay, let's see. Any other new business that people want to bring up? And you can always, between meetings, you can always email us. Have our emails there on the agenda. If you have things that you'd like to place on the agenda for the following month's meeting. But anything that comes to mind that people wanted to mention as new business today? Okay. Chris, you want to finish up with the business items, or?
Sure. While we do have some recordings of past meetings, we're running a little bit behind on those, but what you will find is a copy of the minutes from our meetings on the website, and that we're looking to get those the recordings. I think we've got the glitches from those kind of worked out, and you'll see the recordings being popped up over the next couple of months. Polly's gone. So more to come on that. And
oh, sorry, Chris, I was muted. Yes, they will. They should be. The recordings should be up there, I'm guessing, by next week, and the minutes of the last meetings are on there now. If you go on the website, if you go to, committees and groups, under special interest groups and primary care behavioral health, at the bottom there's a resources tab, and it will take you to all the past meeting minutes. And we'll begin to build that out as well once we get the frequently asked questions, and the toolkit information will also be on that page.
okay. So I guess our next meeting is same time, same place. It's always going to be the first Wednesday of every month at 3 p.m. Eastern Time. And thanks for attending, and we look forward to hearing from you at our October SIG meeting and seeing you at the conference if you're able to make it. Any final stuff, Jeff?
No. I want to just echo that. Thanks, everybody, for attending and for your input. Next meeting will be a good one because it's right before the conference. So hope to see everybody at that one.
Ebony, anything from you?
Nothing from me.
Any parting words, Polly?
No, thank you all so much.
She's on mute.
Right.
Okay.
Everybody have a great day.
Thanks, guys.
Thanks a lot. Take care, everybody.